So this is the 3D CT scan of the pelvis showing a complete fracture of the posterior wall. Almost whole part of the posterior wall is fractured. About more than 90% of the posterior wall is fractured. And see, so our plan is reduction of the posterior wall within the acetabulum and fixation it with reconstruction plate, and as well as removal of the retained fragment in the acetabulum. So these are the landmark. This is the posterior superior iliac spine. So this is the landmark. This is posterior superior iliac spine. So this is a point. This is the tip of the gator trochanter. So this is our second landmark, and this is the shaft. So this is the third landmark. So usual incision is should be from the mid thigh directed towards the gator trochanter, followed by a curved incision directed posteriorly up to the posterior superior iliac spine. So the standard approach is a little bit distal and inferior the initial point of incision. So our mark is, though this is posterior superior iliac spine, so our proximal most incision should be here, and this is our second point, and this is our third point. You can check fluoroscopically the exact landmark. So we will go further check fluoroscopically. Thank you. So this is the fascia lata, and this is the gluteus maximus muscle, and this is tensor fascia lata. So we will divide gluteus maximus into two flat. The anterior half of the gluteus maximus will contain the superior gluteal artery, and the posterior half of the gluteus maximus will contain the inferior gluteal artery. So we will divide the gluteus maximus up to the first neurovascular bundle, that is up to superior gluteal artery and nerve, to avoid any iatrogenic injury to the superior gluteal artery. So we have just divided the gluteus maximus into two halves. This is the anterior half, this is the posterior half, and this is the tensor fascia lata, and this is the subgluteal bursa and fat. So we will now remove subgluteal bursa and fat to remove the short rotator, to expose the short rotator of the hip. Sometimes for the better exposure you have to cut down about of the insertion of the gluteus maximus about 1 centimeter from its insertion in the gluteal tuberosity, and we are now cutting the insertion of gluteus maximus from its insertion about 1 centimeter for better visualization of the structures. The depth of the wound, just below the gluteus maximus, there is the sciatic nerve. You can appreciate. This is the sciatic nerve. Okay, sciatic nerve, and these are the short rotator. This is the conjoint tendon formed by the superior gemelli, obturator internus, and the inferior gemelli. So we'll put a stay suture in this conjoint tendon and cut down, keeping 1 centimeter from the tip of the trochanter. And this is the quadratus femoris. So we can also cut this tendon. So sciatic nerve lies just superior to these two muscles, but it lies deep to please it lies deep to piriformis muscle, but it is completely injured. See, you can watch piriformis muscle is injured. That is why we cannot see piriformis muscle in this case, but we can see the conjoint tendon. Okay. So this is the exposure. This is the head. This is the fractured acetabulum. This is there is a large fragment in the acetabulum. See, you can see there is a large fragment in the acetabulum. This is the posterior wall of the acetabulum. So we will just fix it in this layer, and this retractor is just in the anterior, inferior iliac spine to retract the gluteus maximus and retract the gluteus medius, and this retractor is placed in the laser sciatic notch to retract the posterior layer of the gluteus maximus muscles. And this is the recognition, and this is the greater sciatic notch. So this is the posterior column, and this is the ischial tuberosity. So we'll place the plate in this vicinity of the posterior wall after fixation of the fractured posterior wall. Thank you. Yes. So this is the posterior wall, and this is our main fragment. See, and we just reduced here this with the help of ball tip pusher. Please give me a ball tip pusher. So this is how we will reduce the posterior wall by using the ball tip pusher, and then we will give a K-wire for preliminary fixation, or we can use a suck here. We can use a ball tip clamp to reduce this before using the plate or leg screw.
Before giving leg screw, you have to check all standard views of the acetabulum by fluoroscopy to avoid the danger zones and to avoid any articular penetration. See, here is the screw is completely extra articular.
So we have already reduced the posterior wall provisionally. See, we have reduced with a K-wire and a screw. Now we'll give a reconstruction plate after bending. So this is the final construct. So we have given a leg screw here. This is the leg screw, and this is the buttressing plate. So we have given one screw in the directly to the ischial tuberosity through the ischium, and two screw in the upper and cephalic corner of the acetabulum, and this is the greater sciatic notch, and this is the lesser sciatic notch. And so you can appreciate a nice reduction and stable fixation of the posterior wall. See, so completely stable now. So this is our final construct. Okay. After gluing the reconstruction plate and screw, we are checking the perioperative fluoroscopy again to see the direction of the screws in all standard views of the hip. See, all screws are perfectly placed, but after seeing the x-ray we have decided we will give another screw distally
through the ischial tuberosity, and we are now giving that another screw.
Ischial tuberosity inferiorly, 2 screw posterior superiorly, and one leg screw. So this is a stable fixation of the posterior wall. There is a large, this is a large fragment starting from here to there, about 6 centimeter, about 6 centimeter. So it should be must fixed this, and this is about 90% of the posterior wall. So thank you. So we are repairing the quadratus femoris muscle, the short external rotator of the hip. So see, this is the sciatic nerve. This is the sciatic nerve, and it lies just posterior to the quadratus femoris. So we have already repaired the short rotator. This is quadratus femoris, and here is the conjoint tendon of 2 gemelli and obturator internus. But unfortunately, his piriformis muscle is too much injured and lacerated. That's why we have to exercise the dead and dividalis muscle. So we have already repaired all short rotator except the piriformis, and this is the sciatic nerve, which is lies just posterior to the short rotator, and this is our plate. So we now go close the gluteus interval. So this is the final closure. This is the incision. Here is the This is the posterior superior iliac spine. So this is our standard Kocher-Langenbeck approach. So thank you, and thanks the team for nice operation. Hey, নাড়াও ভালো করে নাড়াও This is the postoperative X-ray of the pelvis, AP view, showing the reconstruction plate which is placed peripherally. One leg screw placed from just margin of the acetabulum, and see the posterior margin of the posterior wall of the acetabulum, which shows concentric reduction, and 2 screws placed distally from in the ischium, 2 screw proximally in the ilium. So nice concentric reduction.